Hello and welcome to Healthcare Innovations Population Health and Social Determinants of Health Virtual Day. My name is Matt Rayner, and on behalf of the entire team here at Healthcare Innovation, a big thank you for watching, to you, our audience, for watching this panel discussion entitled On the Leading Edge, the Role of SDOH Strategies in Population Health. And a big thank you to our friends at TimeDoc Health for their support of this session and for making this program possible. A very quick housekeeping note that I'll mention: if you're watching this session live with us here today on September the 28th, and you have any questions for our faculty, please utilize the chat functionality within the Zoom platform. I would now love to introduce onto this virtual stage Mark Hagelin, the editor-in-chief here at Healthcare Innovation, who will then introduce our panelists and kick off this panel discussion. Mark, why don't you take it away?
Thank you so much, Matt. Welcome to everyone in our audience. I am very excited to moderate this panel, and we've got great people with us. I'm going to ask each panelist to introduce her or himself, and then briefly introduce her himself, their role, their organization, and their connection to the topic, and then we'll get going. I'm just going to go in clockwise order based on what I see. As many people said early in the pandemic when we went into Zoom and other associated modalities, we're in a Brady Bunch world. So I just see people in boxes. So I'm just going to start on the upper left. Dr. Paul Helmuth, why don't you introduce yourself?
Hi, thank you for having me. I'm PJ Helmuth. I have a few jobs. I'm the medical director at TimeDoc Health. We're a chronic care management and remote patient monitoring virtual care company. I'm also a primary care physician. I'm boarded in internal medicine and pediatrics. I still do that one day a week. And I'm in the governance of our local ACO where I practice in Western Massachusetts.
Thank you. Dr. Marshall Chin, if you could introduce yourself.
Thanks, Mark. I'm Marshall Chin. I'm a general internist, a health services researcher, and a professor at the University of Chicago. I co-direct a Robert Wood Johnson Foundation program called Advancing Health Equity, Leading Care, Payment, and Systems Transformation. And I co-direct the Centers for Medicare and Medicaid Services, Healthcare Payment, Learning and Action Network, Health Equity Advisory Team.
Wonderful. Thank you so much. Lindsay Haas, please introduce yourself.
Yes, hello. Thank you, Mark. I'm Lindsay Haas. I'm the vice president at OCHIN of our Member and Network Success. And we are a nonprofit leader in equitable healthcare innovations, and a trusted partner in a growing national provider network. My role is really focused on leading our federal programs, including the largest health-centered controlled network in the country, which is funded by the Health Resources and Services Administration, and programs related to connectivity through the FCC. Yeah, thank you.
Thank you, Lindsay. And Sarah DeSilvia, if you could introduce yourself, welcome.
Thank you so much. I'm happy to. So my name is Sarah DeSilvia. I have the honor in being the director of terminology for the Gravity Project, which is a collective that has the charter to develop the data and data standards to address the social determinants of health. I also practiced a little over half-time in rural family medicine in northern Vermont. And I have for perspective in this conversation, I was the clinical lead for my health service area and deeply involved in the ACO work that Vermont has been doing for some time. So I'm happy to represent those perspectives here today. And thank you for having me.
And I should have asked, what is your clinical background, Sarah?
I'm a family nurse practitioner.
There you go. Terrific. Thank you. So Dr. Chin, Marshall has asked that we all go by first names and not distinguish doctor and non-doctor titles. I will share something super TMI, which was my very first job in healthcare publishing, was with the State Medical Society, at which it was beaten into us that we could never address a doctor by their first name ever. And then in our prep just before we came on live, I said, and that included if you were married to a doctor or had an adult child who was a doctor. So it kind of got beaten into me 30 years ago, but I'm recovering. So, so it will be PJ, Marshall, Lindsay, and Sarah. So thank you so much to everyone. Let me begin by doing a little bit of a level set. What's fascinating to me right now, you know, we've been covering this phenomenon, SDOH, and where we're going in terms of integrating social determinants of health considerations into population health management. And really in the last year and a half, it has just taken on wings and everyone is talking about it. Some people are doing something about it in healthcare, and the level of interest, I have to say, is very heartening. Everyone wants to know what everyone else is doing so they can decide whether they will do something. And it's an exciting time because we've never had so much attention focused on these areas. And we'll talk about this, but I believe absolutely that the pandemic, which of course has been a global catastrophe, did lead to this positive outcome in the sense that people realize how incredibly important social determinants are in terms of overall health and health status and population health. So it's an interesting time. So I think what I'd like to do is begin, and I'm going to throw this out to the panel. How do you see this moment in healthcare? Why are social determinants of health so important right now? And maybe I'll tip it a little bit by saying, what did we learn from our experience of the pandemic in relation to care? And honestly, I'm not sure where to begin. I'm just going to let anyone. Well, maybe Lindsay, would you like to frame this a little bit, because I know you live in this area.
Yeah, I think it's such an interesting point in time for us to be at, coming out of this global pandemic and really thinking about the importance of social determinants of health and how that is really a driver for outcomes, but also it really impacts that whole patient health. And then really what we're seeing is a need for a connected community to support the patient. So we understand they're really well intertwined, but it's really essential that we really understand both those individual and systematic barriers to getting the care that patients need. And it's really developing that evidence-based solutions to drive more health equity and bringing out better outcomes at the end of the day.
Yeah, absolutely. And Marshall Chin, I know that you are deeply involved in this area. How do you frame this moment?
Mm-hmm. So on one hand, this is not new in that I think like any clinician has known and would love to have great systems to address their patients' social needs. It's like one of these like holy grails that when you work in a system that does it well, I mean, it's like magic. And so, we would all love that and see the importance for individual patients, as well as when we think about like population health, community outcomes. And I think too, from an international perspective, like a wide perspective, people here are probably familiar with like the various statistics showing that across like a lot of the Western countries, we don't do well on a whole variety of health outcomes and equity measures. And though when you compare like a lot of Western countries, the percentage of GDP is similar when you add healthcare and social service sector spending. But the US is the outlier where we spend a lot on healthcare spending and relatively small amounts on social care spending. What is new, though, I think, as you said, was that it's both the pandemic, in particular the pandemic inequities, as well as the other secular factor was the George Floyd and police brutality. So there were 2 or 3 major factors that were highlighting issues of social determinants, structural inequities, structural racism, social privilege, and all. And between now the public momentum, and then I think it's also the sense that both from the governmental and market perspectives, it's coming in terms of then a variety of regulations and incentives to both support and require addressing social determinants. So I think that's what's happening, of why it's such a big issue right now.
Exactly. PJ Helmuth, I know you have multiple perspectives because you are a practicing physician. What do you see right now out there?
Yeah, I have multiple perspectives because I have too many jobs. I think, one thing that occurred to me, as you were talking about, what happened in the pandemic, how did this sort of bring these issues to the fore? I think partly it exposed a lot of the ways in which our healthcare system isn't much of a system. Yeah. And it was a real stress test, obviously. And just thinking from the point of view of chronic condition management, if I have a patient with hypertension and then I now all of a sudden can't see them in the office, how am I going to be in touch with that person to know whether their blood pressure is in control? Maybe that person doesn't have good technology access, so I can't do a telehealth visit. I get less reimbursement if I don't do a video telehealth visit. Maybe that person doesn't have access to a blood pressure cuff and can't afford one. How am I going to get the biometric data I need? We see opportunities for some programs to help connect patients, but we really, I think, very quickly exposed that there's a lot of people at risk for not having access to healthcare whenever a stress happens. And we all had to sort of pivot and find ways to reach out to and bring healthcare to those populations, whether it was vaccine programs or chronic conditions management or other programs. And to me, at least, it sort of reminded us that we're sort of on a knife's edge, even on a good day, with how we're doing as far as addressing the access to care and access to health needs of our various populations.
Yeah, and I think absolutely, PJ, that one of the everyone in our society, or practically everyone, I hate to say everyone in our society as a generalization, but people realized how disconnected we were in general from each other. And then when you add that layer of where the healthcare system sits, there were a lot of realizations that happened 2 years ago. And yes, we lost, a lot of patients kind of got a little bit lost in the system for a while. And in a few minutes, we're going to dive very deeply into what you do, Sarah. But just a thought on overall how you see everything right now in this moment.
First of all, it's difficult because I agree with so many of the things my esteemed panel fellows have said. I just want to highlight a couple of things. I just want to pull out what Dr. Chin mentioned regarding what we've known has been long predates this moment. I think about the World Health Organization conceptual framework for the action on social determinants of health. I mean, that's been in existence for a long time. We've been talking about both behaviors, social drivers, and structural drivers and policies and their effect on health outcomes and health inequities for a very, very long time. But if I can highlight what happened in the pandemic is unfortunately catalysts reveal disparities, right? So whether it be disparities in access or disparities in outcomes or disparities, the new data that just came out about the effect on life expectancy and its disparate, whether it's Black and white, like 7.5%, I forget the exact number, or 7.5 years, a decrease in life expectancy since the pandemic. So unfortunately, these kinds of major social events highlight what has been present for a long time, but put it in relief. And so we all are just bearing witness to this moment, and we have a lot of work to do.
We definitely have a lot of work to do. So thank you all for that. Now, when we look at this issue, one large element, of course, involves creating connections along a chain of interaction from the primary care physician-patient visit to the internal documentation in that physician's practice, communications around social determinant issues for individual patients, to screenings, and then to what happens after that. One of the challenges that we know is, as I like to put it, the track beds have not even been laid for a lot of this. So, I sometimes like to bring up an analogy or a couple of different analogies. I'm kind of fascinated by the early days of the automobile and the telephone, and also the creation of the Transcontinental Railroad, where they literally were like hacking into rocky soil, you know, in the middle of the Rocky Mountains. If you look at the early days of the phone and the automobile, everyone was kind of trying to figure out what we were doing. You know, the first cars were all custom, and they were putting the brake pedals and the gas pedals in different places. It was pretty chaotic. So one of the challenges we have right now is just kind of figuring out how we as a health system do this, right? Individual organizations are certainly getting into it, but there isn't yet any kind of broad systemic understanding of exactly how we should do this. And I think that's one of the challenges, right? Marshall, would you like to address the fact that we've got thousands of flowers blooming, but they're not all right? Everybody's doing something a little bit different, or even a lot different.
Yeah. Well, you know, on one hand, that there are some aspects that likely can be standardized. So, for example, some of the basic data elements, some of the basic screening type of questions, you know, you don't want to have like providers having to deal with like multiple different systems for different insurers and different payers and all. So some of that can, and we'll hear more from the Gravity Project, some of that can likely be done. But on the other hand, some things probably are better left tailored, that, you know, what will work in a frontier Idaho site may be very different than, you know, the big academic center in South Side of Chicago at University of Chicago. So I'd be careful about doing too much standardization. I think maybe a larger point, Mark, is that in some ways, this is quote, which I attribute to the football coach, Bill Parcells, that the outcome you get is exactly because of the system that's perfectly set up to get the outcome. And we have lots of outcomes regarding addressing social determinants. So I think it means that, and I think the will is there. I mean, again, clinicians want to do this, but it's a matter of overall in healthcare, the culture is not such that it is truly highly prioritized. Then the payment systems are not aligned to support and incentivize these types of care transformations that can address both the medical and the social to improve health and outcomes for all.
Exactly. And Lindsay, I know you face those kinds of dislocations and gaps every day in your work. How do you see that? How do you see the fact that we're like a million different organizations doing things a million different ways?
Yeah, Mark, that's such a great question. And your analogy on the railroad and hacking into rocks, we're still doing that for connectivity and broadband in this country. So it's a really strong analogy there.
I didn't even think about that. Yes.
But when we think about the perspective on prioritization and that we know clinicians and providers out there have only so much time to do all of the work that they're being asked to do, and thinking about the tools, let's just look at the function of our tools and how those work. We're really needing in the system integrated, multilingual, culturally responsive tools that are easier for both patients and providers to navigate. And we really do see some promise coming out right now with tools such as Epic's Compass Rose or integrated social service resource locators. But we still have connectivity issues to support those tools. And then, the clinicians, there's only so much they can do in one visit or in that appointment time. So really thinking about leveraging everyone within the system at the top of their license. And then there's skills to actually asking these questions. These are very sensitive pieces of information we need to have training on. It's not a standard way to ask somebody, how's your housing situation? You have to have some level of ability to navigate that. And then finally, I just think it's just, let's keep thinking more globally, collecting this data systematically. And I do believe standards will allow us to take a step back and start addressing some of these gaps when we're able to have all of the data points. So, yeah.
And then in about 1 minute, I'm going to plunge in and turn to Sarah. But before I do that, PJ, could you especially put your primary care physician hat on for a moment and talk about how this looks? you have a patient visit, right? So Mrs. Smith comes into you and you're the physician. Physicians were not trained in medical school to do this. They were not trained as social workers. And at most you got just a little bit of, coaching around the edges maybe. But what is this like right now? And in many cases, physicians are practicing in smaller practices, or if they are practicing smaller practices, they don't even really have the front desk staff that's trained in any way for this, right? Now, fortunately, in the largest multi-specialty groups, you do have some infrastructure for this, but it's challenging. What does this look like to a primary care physician?
It's a great question, and I think it's one that we always have to sort of keep front of mind as we work on these. That is to say, as we transition into value-based care, it is clear that social risk factors are big drivers of health outcomes and of utilization, and so we need to start thinking about them because that's part of how we're going to be orienting our practices and the way that we're going to be thinking about the care that we deliver based on those outcomes. On the other hand, in the midst of a day, if I have 20 people on my schedule and I have to remember all of these different clinical practice guidelines I'm supposed to adhere to and make sure that I'm giving good patient care so that my patients have good experiences of care, and I'm trying to get them into the specialists who are no longer seeing patients because their practices are overwhelmed. I've got a pretty busy day. And in the meantime, to try to figure out what am I going to do about housing insecurity or about food insecurity? What is my role if this a patient has transportation problems and can't get to the appointment that I'm trying to schedule her for? That's a really hard thing to lay on the plate of a primary care physician who has lots of other things going on without figuring out what are the local resources that we're tapping into, what's the best way to access those, and what does a team-based care model look like that allows us to find out what the needs of the patient are. The clinician should be aware of them, but that person should have the ability to help close the loop for those things in a way that doesn't feel like it adds to the problem of physician burnout, where we just see way too many tasks that we can't ever possibly accomplish. Unfortunately, we still practice in a model where we expect the clinicians to take care of the lion's share of the work that needs to be done for the patient. And as much as we talk about team-based models of care, we have a hard time transitioning to that in most practice settings. So to me, it seems like that's the place where things fall apart a little bit. Just saying, hey, oh, and by the way, one other thing, make sure you is always going to be problematic unless we think about the infrastructure we build around the physician practice.
That's such an important point, PJ, that there's so much that really devolves down to, well, if only the clinician worked harder, the buck stops there, but you can't get blood out of a stone. And the problem is that it requires really sort of the whole organization to transform. It's not going to be a simple fix. That what may seem like a simple fix actually requires like 10 or 12 different units across the organization to coordinate, let alone then developing the culture where people truly prioritize addressing SDOH. So it is a systems problem, not an individual problem.
Absolutely, Marshall. And I think, PJ, you put your finger on it exactly, which is all of this cannot fall on the physician who has, in effect, 9 minutes, with the patient. It's just too much. I love to use that average. I have been with a specialist where I had, in effect, 4 minutes. So we know what that's about, but that's a subject for another whole discussion. So now I want to plunge deeply into the deep end of the pool with Sarah. Sarah, I am so thrilled that the Gravity Project exists, that it's moving forward, showing leadership. Many in our audience will not even know what the Gravity Project is. So I think you'll have to start a little bit at zero. Tell us what the Gravity Project is and the context of its work in the context of everything we're talking about right now.
I will do my best, and I'm going to try to segue in through building off of what was just being talked about. So again, echoing from my fellow panelists, these are not solutions that are even easily found within the health systems we work in. I speak from the humility of being deep rural primary care and the resources or lack of resources that are available in my community. So the solutions that we find to social problems are by nature found in communities, right? Like cross-organizational education, departments of health, community-based organizations working together on them. And this makes me think again about the World Health Organization conceptual framework, right? So we will continue to address the tide if we don't look to structural solutions as well. So really trying to maintain hope by working on policies that actually create sustainability and address inequities is a huge part of what I do, just to try to make my not feel like I'm yet again addressing the stream without addressing the source. Yeah. Toward that end, that is really the origin story of the Gravity Project. The Gravity Project is this wonderful, large, 2,500 person strong public collective, which was formed out of the charter and the recognition that one of the an unnecessary barrier to addressing social risk was really the absence of language and standards regarding the data that we have available to us in both clinical and social care settings. Data justice has this principle of one of the primary injustices is the injustice of invisibility. Can I name the thing I see, right? So the Gravity Project is a consensus-based initiative that develops data standards for each social determinant or social risk. So for food insecurity, transportation insecurity, housing instability, homelessness and its subtypes, the list is long. We have gone through approximately, I think it's like 14 domains at this time, and building language that mirrors the practice of clinicians and teams and community health workers and community-based organizations and how we care for patients and clients. So building terminology for the screening tools we use, building terminology for the critical diagnoses and problem statements, building terminology for patient-centered goals that in patient voice, and building terminology for all of the core interventions that align with both local and federal programs. So thinking about food insecurity, everything from local food vouchers to all the critical USDA programs or Older Adult American Act programs, right? So this is addressing that injustice of invisibility by creating the language, but it also helps the standardization element because we curate all of these data sets within the Value Set Authority Center at the National Library of Medicine. And we make sure every single data element is defined and based on evidence-based language through technical expert panels. So then you're able to have some of that standardization of practice. I don't have to choose one tool from the myriad of tools to address food insecurity or transportation insecurity. There's a recommended set that's been validated by experts. It's freely available, and it's available for use in any use case, whether it be direct clinical care, population health, or even alignment with the upcoming HEDIS and CMS quality measures. So the goal really was to address the injustice of invisibility and address kind of the complexity and cacophony within the clinical space by creating data and data standards. I hope that was a good answer.
That was terrific. And I love the word cacophony. I mean, that kind of is what it is. So other panelists, I'll start with Lindsay, but everyone, listening to what Sarah has explained, how does the work of the Gravity Project tie into what everyone is trying to accomplish out there?
I think what they're doing with the Gravity Project is incredibly important right now. You know, we need that data standardization. Having that lack of it really inhibits us with research, policy discussions, as well as the innovation that we need to address these barriers and risk factors. And it's really critical as we start to think about payment and delivery reform around value-based pay, and ensuring that these communities are set up to absorb those needs to really make this a viable possibility in the future here. And so we really do commend the Gravity Project here at OCHIN and the strides they've made in this area. We know there's still more support needed there, and funding needs to follow this. There is not funding for these questions to be asked and documented. the tools need to continue to be developed. And if there's funding, that'll drive development there. And then that will allow us then to address those larger gaps in our overall system.
Terrific. And in about 3 minutes, we're going to plunge into the whole topic of value-based payment and delivery. PJ and Marshall, when you hear Sarah explain, and I'm sure you're familiar with Gravity Project, but when you hear her explain, frame what their work is in the context of everything that we're hoping to achieve as a system, what are you hearing? What comes to mind for you? PJ, why don't you go, and then Marshall?
Sure. I have to say that I have a little bit of sort of personal experience with this, in that I had the honor of representing our health system at Massachusetts Center for Health Information and Analysis. CHIA had a work group on social risk factors, and it was about 4.5 years ago. And at that time, the question was, can we gather data from the hospital systems across our state and figure out how to use it to kind of compare systems and find out what social risk factors their patients are experiencing. And we came to this problem of, we didn't know what to call different elements. We didn't know, the hospitals weren't really consistently collecting the data, so we didn't know how to aggregate it or to analyze it. And we spent the first 2 meetings trying to figure out whether we were going to call them social determinants of health or social risk factors. So, you know, we just really had a lot of trouble with nomenclature as well as data. And so I see this as a really big and a very important project, both from the state level and the federal level, but even for local communities, is figuring out what's the language you were using, and can we begin to start collecting some of the information that allows us to see where the populations of need are in our communities. Because you know, at least 4.5 years ago, we weren't even able to make much progress in that.
Absolutely. And Marshall, I know you're very involved in so many things. What does the frame around the Gravity Project look like to you?
Well, I think it's great that our experience is that when we talk to different stakeholders, organizations, it can take teams literally months to agree upon a definition for social determinants or health equity, a variety of basic terms. And so as the Tower of Babel, getting down to a uniform language understanding is critical. I would like to highlight one additional point before we go to payment, that language is important, but it's different than the actual implementation and target goals in a sense. In other words, we haven't talked much about how there's the perspective both of the individual patient, of us trying to help that individual patient that comes to one of our clinics. And typically we've talked about things like screening for social risks, referring to the relevant community-based organizations, and the closed loop where the information from that community-based organization gets back to the healthcare system. That's one level. The other level is more what I would call sort of a systemic structural addressing of the social determinants in partnership of healthcare with the community and social agencies, public health, that's related, but a separate from the specific, what a lot of organizations tend to focus on is the purely like screen and help the patient in front of me. It's really both that is the mission, the individual patient, then the wider social structural drivers.
That's it. Oh yeah, please go ahead.
I just want to echo what Dr. Marshall Chin just was saying, and to kind of build up on that. So as I was mentioning earlier, the solutions really are found in communities. We say that in Gravity all the time. We might identify problems in clinical settings, but we solve them collectively. And I want to note that part of that, we talk a lot about social risks, and we follow in Gravity the Alderwick and Gottlieb lexicon, which defines social determinants, social risks, and social needs being those patient prioritized elements. But we can't forget when we're talking about social determinants to talk about protective factors and the elements that are not risk as well, because social determinants include both positive and negative aspects. So I don't want to leave talking about data without talking about building data to address protective factors as well. I faculty in pediatrics at the College of Medicine, so it's hard for me to not speak to the documentation and the research and developing protective factors and identifying them in balance to identifying risks, especially when you're working with communities.
Very important points. Thank you so much, Sarah. So now we do want to plunge into the whole value-based discussion. I will just say that what is the great part of this is finally, at a health system, national health system wide level, we're having the discussion, right? That part of value-based care delivery and payment has to be connecting overall health status to the medical part of health. We all have heard, the estimate that only 20% of our health is connected to the healthcare system, connected to medicine. And of course, everything else is everything else. Even people with multiple chronic diseases who may see their physician once a month, still, 98% of the time, they're not in a clinical setting, right? They're in their home, they're out in the world. And one of the challenges is our whole healthcare system has evolved forward as many people have said, a sickness care system. And so now we're trying to backfill or fuel the plane in midair or turn the ship around in mid-ocean. There's so many analogies, but anyway, metaphors. But we're trying to now create a system out of what has been a sickness care system and make it much more than that. And so what's fascinating to me is that more and more, the CMS leaders have said, for example, that health equity is going to be a gigantic part of everything that they do under Medicare and Medicaid. So that gives signal direction. And more health plans, private health plans, are saying, yes, we fully realize that we're dealing with people, right? Not just body parts, right? But putting that all together is really challenging. So I'm first going to ask the physicians and then everyone else, how does that sound to you, the fact that we're now trying to create value-based payment systems that somehow incorporate ideas of social risk, social determinant, whatever you want to call it, but it's awkward, right? So Marshall and PJ, what are your thoughts?
So much to say. So I'll start things off. So I think maybe the fundamental problem is that the current healthcare system is not designed to optimize health. Powerful financial interests is really sort of like a lot of it's sort of like profit-driven and all, as opposed to optimizing patient and community health. And then when people talk about things like value-based payment or alternative payment models, they're often vague, where they assume, oh, well, it's to shift from fee-for-service to VBP and APMs. Magically, this will improve things. Not necessarily so. I like how you gave this analogy of like the railroad, putting down railroad tracks. There's a similar analogy here that we need to do a better job of connecting the dots between, an abstract concept like payment to what are the different specific dots you connect then to lead to the better patient and community health. So we have this mantra for our program where, and I mentioned a little bit earlier, it's basically, it's not payment reform for payment reform's sake, but payment reform that supports and incentivizes the care transformations that address the medical and social needs to advance health equity, to improve the health of everyone. And so a lot of times then, like, you'll see like faulty thinking if you try to make the connecting the dots in like current programs, because they haven't really linked to why a different policy change, whether it's a, P4P program or some type of global payment program. What is it about that should lead to the incentive and support to change the system to address the social needs to improve the health for all? I'll just mention one other thing here that, well, maybe three more points that, like, when you think about payment, I think about it in three different areas. One is, what do you do in terms of like upfront payment, whether it's a per member per month, or it's a global cap or payment or whatnot, which can help support the infrastructure, like the data systems, like the personnel, like the CHWs and all, to do this type of work. Second lever is like P4P, basically, what are the reward systems that reward, meeting certain metrics that would drive social determinants? And the third, which we haven't talked about yet, is social risk adjustment for payment. So that, like, a huge issue is that, like, for OCHIN centers and all, and probably for your site also, Sarah, if you serve a more vulnerable population, you get killed oftentimes in terms of the payment systems. So somehow the payment systems need to be equitable in terms of adjusting for patient social risk.
Yeah, that's absolutely true. And one of the interesting things for me is how, as you know, like for example, I have been following very closely all the developments in the kind of perils of Pauline saga of the Medicare Shared Savings Program. And one of the elements, and we could go down a rabbit hole, so I promise I won't. I'll just make a quick reference. But there was a kind of a big fight broke out over a span of a couple of years between Seema Verma and then some of the ACO leaders, such as at NACOS, because as they were trying to move forward in the MSSP, and in theory, that would help everybody, right? It would improve health status for everyone. The benchmarks kept tripping up the providers, and the providers were saying, well, if you want us to stay in the program, you have to reward us continuously. I mean, I'm obviously paraphrasing, they didn't say those exact words, but you can't make it harder over time, right? So this does get into social determinants because they're trying now at CMS to really think about health equity in terms of rewarding providers that are caring for the most vulnerable patients and those with the greatest social needs, so that so that the CMS is not implicitly disadvantaging providers who are caring for vulnerable populations. It's really complex, right? And I think that one of the great challenges there is the traditional ways of looking. Well, traditional is so funny because we've only been doing value-based payment for a few years now, but the ways several years ago of thinking about this, we're starting to get clarification that we really have to put social determinant and social risk issues into the incentives, right? Mm-hmm. That has to be a piece of value-based payment. Otherwise, we'll never get there. PJ, I know you're having thoughts. I can see your mind working. Is there?
That's frightening. Okay. Yeah. I sort of coming off of what Marshall said there. I think, from our ACO's point of view, we're responsible for 40-some thousand Medicare beneficiaries with a budget of approximately $500 million. And we have to sort of figure out, we had two-sided risk in MSSP, how do we come in under that budget? So that means we're gonna have to make some investments. Maybe we invest in care coordination, care management programs, because we think that'll help decrease our utilization. Maybe we invest in a coding program so we can improve our coding and increase our budget. But we're going to have to make some investments. Now, we know from looking at the data that patients with social risks, patients with behavioral health problems, that many of those people are going to spend more money in the healthcare system, but we don't know who those patients are. And if we identify them, we don't know how we're going to deploy resources in the community in order to decrease the costs. And we haven't even really proven that we can. So now I've got this budget I need to come in under. I don't really know whether a big investment into making sure everybody puts their Z codes in, making sure everybody does a social determinants questionnaire to identify risk factors. Is that going to return on investment in my $500 million budget? And if so, how long is it going to take for that to happen? And so there are very real questions in the value-based care world today as how much can we invest into these type of programs. I think the incentives are going to have to make it so that we do it. I'm always interested in the sort of analogy of EHR implementation, right? Like, we didn't go from 10% EHR adoption to 90% in a little over a decade because EHRs are awesome. We did it because there were incentives, and we figured out ways to make it so that there were carrots and sticks, and we had to do it, and we got there. And I don't think that we're going to move forward on really addressing social risk factors until we figure out what are the right carrots and sticks to put into our value-based care programs so that our payments go up if we have a higher population of patients with social risks, and we get some infrastructure money for collecting the data and deploying the workforce we need to help with it. But until we have some structural change in that way, it's hard to imagine that somebody's just going to say, well, here's how much money I have. I think I'm going to make a big investment. I hope it works out. It's hard for maybe others are more hopeful, but it's hard for me to see how we get there.
Yeah, and I will say to that, and I don't want to open up another whole can of worms, but there are people, leaders and observers who believe that we have to go towards some form of capitation in order to get there. We had a panel a year ago, and one of our panelists was Stacy Harantas, who's the CEO of Sharp Staley Medical Group in San Diego. And they've been doing capitation for 37 years. Now it would be 38 years. And she said that makes all the difference, because now you're treating all patients with an eye towards longer term health status, right? And you're moving away from the sickness care model much more quickly. So, but that's just a thought. Lindsay, I know you have thoughts. I've been seeing your brain work too here.
Yeah, I wish we all had a crystal ball and it all told us the same thing right now in this point in time. It's just, we're on a trajectory here, but I think it just comes back to health and well-being are intertwined, and we have to start thinking of it in those terms, planning for it, partnering with those community-based organizations. When we're doing one requirement on the healthcare side, we need our policymakers to think about how that connects to the other systems in place, and we really need to find a way together to forge this path forward. And it's going to take integration of our social services and in healthcare to some level to really be successful. And I think the goal of value-based pay or payment and delivery reform ultimately is to reduce our costs in our system and increase outcomes and really focus on that wellness piece. And it's probably the triple aim. I heard last week it's up to the quintuple aim. So, but I really think if we think
I knew about the quadruple aim. I didn't know about the quintuple.
I didn't either, right?
I don't know what the fifth is, but anyway, go ahead, sir.
That's okay. Yeah, breaking news there. But it's really just about, I think always start with the patient first, meet the patient where they're at, meet their direct needs. But then us here listening to this and on this panel, what are we going to do about it at a bigger level? And I think that's what we really need to be thinking about.
Yeah. And now I'll insert data, right? Because we have to have this high level strategic thinking and mission driven thinking and vision driven thinking. But then how will data help us? How will analytics help us? Ultimately, hopefully AI can be used in some way in this area. What do we need to do data-wise? And I'm talking about data analytics, but I'm sure, Sarah, you'll have some thoughts how, terminology and using the data in certain ways. But where does data fit into this moving forward process?
Okay, I'm going to do my best, and I'm going to share some of my answer, of course, with my fellow panelists. It was hard not to chime in because in talking about Medicare Shared Savings Programs and value-based care, that is my own personal origin story when it comes to data, was the absurdity of representing medical-only risk and care management allocation. So knowing that the social drivers are there, but not having them not be able to be part of the calculations of distributions of resources and services. So that was literally like my push, right? And it's a huge gravity focus as well, specifically developing claims-based ICD-10-CM language with looking forward into futures where, already the Johns Hopkins ACG score now includes, has a social risk element, really trying to think what HCCs would look like if they included a social risk element. Like, how do we represent social risk if we understand them to be such drivers of outcomes? So certainly some of the claims-based ICD-10-CM data we're building at the Gravity Project. We've built ICD-10 terms for food insecurity, and transportation insecurity comes out next month. And then housing instability, stratifying different types of homelessness. So our sensitivity to the need for data within value-based healthcare is part of everything we do at Gravity across all of our different activities. So that's my quick answer. And then one of the things also I want to say is that as systems have been trying to represent social risk, we've been looking to lots of really population data that looks at community healthcare, at community trends and community risks, but that population data tends to miss those individual protective factors or resources. So when we're looking at really like true population health data that can be driven from the person level up into aggregation at a population health level, that's going to be a really interesting comparison, because if you're comparing population health data driven by the person to community data that's aggregated across public and available resources, you can start to see some of those community drivers like food access, transportation, elements that can't be overcome without really structural resources. And the last thing I'm going to say before I go is just when we speak about and AI, just being sensitive to the fact, again, from a data justice perspective, that objectivity is not assumed. So every algorithm we create, every AI solution carries the bias of the builder they're designed. And so we want to make whenever we're designing algorithmic solutions that we are trying to ensure that we're addressing inequity by design, so we don't.
Yeah, absolutely, Sarah. And thank you for mentioning that. One of the big discussions in the AI area is how we deal with implicit bias. And that's going to be huge. I just have to bring up two little tiny examples that speak to the bigger issue. Like, take these two little examples and multiply them by a factor of like 1 billion, right? So we had on one of our in-person panels a few years ago, the person she was a CMIO of LA Care, which is the Medicaid, or in California, Medi-Cal plan in Los Angeles County. And she was talking about how many of her clinical case managers, who are primarily RNs, end up being detectives. They have to find the members, right? And as we all know, most people aren't truly homeless. There are many in this country, but most of the people who are homeless are kind of semi-homeless, right? They're kind of couch surfing with their third cousin once removed and moving around. And so what the CMIO told us was some of what they had to do literally was go find people, right? Like, where is Mrs. Smith? She doesn't have a phone that's stable, a phone number. She like literally you would spend a week finding Mrs. Smith. So look, multiply that by a huge factor. And then one of our awardees in our Innovator Awards program years ago was the medical director the CEO of a physician group practice near Galveston, Texas. And literally this was about 8 years ago, so this is a long time ago in terms of our discussion, but literally giving bus passes to some patients was like they weren't showing up for their PCP appointments. And if they don't show up, you don't, nothing happens, right? You don't evaluate them, they don't get their meds, all these things. And so we're looking at really basic stuff, right? Like, how do you get patients to their appointments? And then how do you find them? In some cases, literally find people. And then you multiply that. So I think when you're talking about data, one of the things that we have to be able to do as a health system is just account for everyone, right? Clinicians, any thoughts about those little examples?
Well, I think you're right, Mark, that true population health management includes everyone, including people that aren't the people that come into the system. So it does require that broad outreach. I think, like PJ in his most recent comments raised an important point that we really haven't made as salient, which I just want to emphasize here, where he was saying, like, especially for his Medicaid ACO, that the requirement is cost savings. as opposed to value per se.
Yeah.
So in some ways, there's a double standard, especially for the most marginalized populations of the interventions have to work and save money. There are going to be relatively few interventions that save money across the board. Social determinants, it may be like the highest risk category that there's the bang for the buck, but the vast majority probably it's not going to be cost savings. So I guess this issue then of like, well, you know, do we truly prioritize then improving the health of all? And I was on an airplane yesterday, and my colleague Harold Pollack gave this analogy that I found really helpful. So I usually fly Southwest out of Midway Airport in Chicago, which is fairly egalitarian airline. I flew to Paris last week on United Airlines, and then for many middle class, upper middle class people, the airline experience is like, you know, one of the few times it's so salient, like in your face class system. You know, you're boarding Route 3, or you know, you walk through business class, and then like the next business supreme class, and then get to, you know, economy class. But he made a point that in some ways this is the perfect use of a pay-as-you-go system where, regardless if you're in the lowest class or the highest class, you're going to get to that Paris. You're going to get to wherever your destination is. So everyone gets that adequate level of health outcome. If you want to pay more for the champagne before the flight, $2,000 more or more space, all the power to you. But what we haven't done in our healthcare system is make sure that that floor of everyone having that fair, just opportunity is there. That's a huge problem. And so the cost savings requirement is a killer if that's the way that our system looks at the world, because a lot of the stuff we're talking about won't be cost savings.
Yeah, that's a very important point. We really have to think of health equity as a core value. Believe it or not, we're running out of time. So I'm just going to ask each panelist to leave us with 1 minute of wisdom or advice, just something that you'd like to leave with the audience as we get ready to say aloha. Let me go in reverse order. Sarah first.
Oh, well, it's hard to go first. So I guess out of all of the things that we've said, I think I just want to stress the idea that as much as we've talked about clinical complexity, I really just want to stress that these are community solutions, right? So I had the honor of leading my health service area, Accountable Community for Health, for 6 years, right? And it was a wonderful example of what I was not taught, what I did not know, and who really were the experts in the solutions I was trying to find. Because I to this, and even though I was a farmer before I became a nurse practitioner, so I've done this work in different ways, but there are experts out there, they're in our communities, and they want to help. And they want to help not only to help the clients, but also just so they're part of the solutions. Otherwise, we're shifting burden on them. So that's my takeaway.
Wonderful, thank you. Lindsay.
Yeah, so parting thoughts, no pressure here. I think it's really thinking about the timing of where we're at. The opportunity is now. Let's keep driving to evolve our health system to center around the needs of our patients and their families. And really, I think it's really to do whole health or whole patient healthcare. It's going to require whole connected communities of care. And that's where I'd like to leave today. Thank you.
Wonderful. Thank you. Marshall.
I think it's a great time to be working in social drivers of health, and that you can follow your heart. That, you know, the vast majority of clinicians and healthcare folks that I know, they want to address social drivers because they know that it will improve patient and community outcomes. It's the right thing to do. I think, like as PJ said, that ultimately it's going to require a variety of carrots and sticks along the way to get there, regulations and incentives and all. And what's happening is that it's coming, you know, and so that, again, governmental and private markets is going to happen. And so even from a pure self-interest standpoint, got to start getting into this area to get experience doing it, because it's going to happen. And when it happens, it may move fairly quickly. And so you got to get the experience now. And of course, it's the right thing to do.
Wonderful. Thank you. And PJ.
Yeah, I think to me, the one thing that comes up as sort of top of mind in these is really sort of the final pathway to connecting patients and people in our community to the services they need. And I'm not sure we've figured that part out. You know, in our community, we're trying to figure out what's a community health worker, what's the training they need, how much pay should they get, and how much should nurses do, what should be in the home, what should be virtual. I think we have a lot to figure out as far as the infrastructure that the health system owns versus how it interacts with the community and where those lines are and barriers. How do we support the community without reinventing what they do? And to me, I think that's a really interesting place for us to explore is, you know, what are the things that are sort of quasi-health that we should own in the health system side? What are the things we should partner with? And how do we improve the communication so that we are, you know, not only, you know, looking out for people's privacy, but connecting them to the services they need?
Yeah, absolutely. And I'll just bring up the cars and phones again. The first cars were all custom built, and people were putting the brake pedal and the gas pedal in different places, and people were just driving out and crashing. And ultimately that led to the Ford system where, you know, you had a production assembly line. In phones, there were the first city with a full phone system was Kansas City, but there were 4 phone companies, and you could only talk to people if you were a subscriber of the same phone company. That ultimately led to the Bell system because that was unworkable. So we're going to have to get up to a high level of system integration and coordination so that we can get some of those solutions. And so anyway, I love the early history of phones and cars. You've all been so fabulous. Thank you so much. We've covered a lot of territory. We could have talked for another area, but Marshall, PJ, Sarah, Lindsay, thank you for your expertise. Thank you for your involvement and your commitment in this area. And people like you are helping to lead the healthcare delivery system forward. So we really appreciate it. And Matt Rayner, our publisher, is back. Thank you so much again, everyone.
Thank you.
Thank you, Mark, and thank you, panelists. Really just a fantastic way to kick off this Population Health and SDOH virtual day. We do have a number of other wonderful sessions that have now been added and pushed live that our audience is available now to our audience. We encourage you to check out these great additional sessions. Also, just a note here that I have, be on the lookout. In March of 2023, we'll be releasing the Population Health and Care Management Executive Handbook, which will almost certainly be the definitive paper on these very timely topics. So we wanted to share that information. With that said, we want to wish everyone a wonderful day. We look forward to collaborating again soon. Take care.
Thank you all.
Thanks very much.